So thank you for the invitation and giving me the occasion to discuss our French experience of prostate cancer diagnosis based on the recommendations of the French Urology Association. So I was very lucky to be a part of the last guidelines panel, who've just published this update on the French guidelines for the diagnosis of prostate cancer. Published in November 2022, and which will be guiding our practice for the next 2 years to come. But I think when we are discussing the guidelines, it's important to see how did we get there and what decision did we make when discussing the literature and to recommend and make the choices that we made in these recommendations. So let's see, how did we get here? How did we interpret the literature and how did we propose the changes we made? And just quickly to set up the scene, a few numbers of prostate cancer in France. So it's the first cancer in men and the third cause of cancer-related deaths in France. So that's about 50,000 new cases in 2015. It is slowly decreasing by about 3% each year. And it represents roughly between 8,000 and 9,000 deaths each year, and also decreasing by about 4% each year in the 2010-2018 period. But let's not forget something that's very important in the field of prostate cancer diagnosis, and that's the tendency to focus on these 8,000, 9,000 deaths and forget what's behind the tree. And we have a saying in French that says, look at the forest, not the tree, or make sure that it's not the tree that's hiding the forest. And I think it's very important to remember that we as urologists, radiologists, and radiation oncologists must not only focus on the tree, which is reducing the number of prostate cancer deaths, but we have to make sure that the tree doesn't hide the forest. And the forest is all the patients we are diagnosing with low-risk prostate cancer and the risk of over-treating all these patients. So that's something we have to keep in the background to make sure that we don't expose the men to overtreatment, and that we make sure that, yes, we do reduce prostate cancer mortality, but we don't do it at the cost of increased overtreatment. And that's something that's very important. So how are things in France and how have they been for the last 10 years? So as you probably know, there is no organized screening. So we do not offer every man in France to receive a dedicated screening for prostate cancer. But instead, we are offering opportunistic screening. So that is trying to find the men who, if we don't detect early prostate cancer, may risk dying from their prostate cancer. And the strategy that we have, and I think you probably have the same, and I'll be happy to discuss that afterwards, is an early detection strategy. So try to find the cancer in the men that are most at risk of dying of prostate cancer without doing systematic screening and risking too much overtreatment. So how does early detection work? So first of all, we want to consider patients, or men, not patients actually, who will benefit from treatment if they are diagnosed with prostate cancer. So we chose this threshold of 10 years life expectancy, but of course the threshold will be different if we find prostate cancer, whether it is low risk, intermediate risk, or high risk. But we want to make sure that we do not miss significant disease in younger men and very significant disease in less young men. So again, to make sure that we don't overtreat. So first of all, we only consider men with a long life expectancy. Once this is done, we'll have to consider if the man we have in front of us is at a particular risk from his family history, for example, from his ethnical origin, or maybe from an already known gene mutation, such as BRCA2, which we know will expose men to more frequent and especially more aggressive at an earlier age prostate cancer onset. So these men will be of particular interest in our early detection strategy. Then once we've done all these evaluation, we will use the tools that we have available. So the first tools we use will be PSA testing and digital rectal examination. And digital rectal examination still has quite a large place in France. I think it's quite normal for a man seen by a urologist to have a GRE. I know it's not the same in every country, especially with MRI. So that's something I'll be also happy to discuss afterwards. And we won't only consider PSA, but now we know that PSA density is of much more interest. And of course, the evolution of PSA. And all these information will let us know whether the man, one, has a long life expectancy. So if he will benefit from an early detection strategy, if he's at a higher risk, estimated from his history and also from his PSA and GRE. And we can also use the help of risk calculators. And all this will lead us to an estimation of the patient's individual risk. So this is all summarized in the latest version of our recommendations. So we consider males with a probability of survival of over 10 years. An important thing is that we try to avoid having men being prescribed PSA testing with all the blood tests that they have each year for diabetes, for kidney function and everything. It used to happen a lot. I think it's getting much better now, because it's important to offer the men the option of refusing to have early detection if they don't want to, if they don't want to know, or at least to make sure that when they have the test done, they know what it implies in terms of further explorations, in terms of potential treatments, and in terms of risks of the strategy. And the risks include, of course, the need for active surveillance and the need for treatment and sometimes over-treatment. So it is important that the patient receives an information before starting early detection. It is important that the patient consent to the PSA testing. Well, DRE makes sense. It is screening for a family history of prostate cancer is very important, because we know that men with gene repair mutations will be at higher risk of having significant prostate cancer. And of course, identifying patients with an ethnicity that puts them at higher risk of prostate cancer and significant prostate cancer. Then, as I just explained, we'll use DRE and PSA. And an important question is, when do we start early detection and when do we end early detection? And that's a very important subject of debate in the guidelines panel. But usually what's important is that there's a tendency towards the start of the early detection strategy at a younger age. Like, we put all the effort we can to detect cases in very young patients that we know will have bad outcomes if undetected. And we try to release the intensity of the early detection among older patients. We have data from France saying that the peak of PSA prescription is around 75 years old. That's not good. That's something we really have to work on, because men don't need to have their first PSA done at 75, or at least the majority of men don't need to have their first PSA at 75. So we really want to have a shift in PSA testing to have it done earlier, rather around 50, between the age of 50 to 60. That's where we're looking at. Frequency will depend on the individual risk, but we'll come back to it. So what used to be the prior early detection pathway? So we've seen how to estimate a man's individual risk. Based on these estimations, we'll have two situations. Either we deem the man at low risk, and then we'll repeat the early detection until life expectancy reaches under 10 years. The frequency will be adapted to the risk. Like if the PSA is very low, GRE is normal, but the patient is a mutation carrier, of course, we'll be repeating the test more frequently than if there is no genetic context. If we deem the man at high risk, well, what did we used to do? What we used to do was do a biopsy, and then we had three possible outcomes. The first one was a negative biopsy. So we were reassured for a while, and the man went back to the low risk category, but we know that it was not that simple. And very frequently, the man came back to the high risk and had another biopsy and repeat until we finally stopped early detection strategy or detected prostate cancer. The biopsy could be positive, but with a non-significant disease. So that was a problematic outcome, because either the man would be treated, and we now know that it was overtreatment, or it would be offered active surveillance. And we all know that active surveillance involves a lot of energy from the physicians, but also some anxiety from the patient. And we put a lot of effort into repeat tests, repeat biopsies. And at the time, repeat biopsies were done through a transrectal route with the risk of sepsis and complications. So I would say this was not a good outcome. And of course, in some cases, the biopsy was showing significant disease, and then the patients had treatment. And then we were happy because we had actually helped the patient. So there are many situations that we actually wanted to avoid, such as unnecessary repeat biopsy, unnecessary biopsy, and the overdetection of low-risk prostate cancer. And the field could have stopped there, and we would still be talking about discussing the same things. How many biopsies should we do? How should we do the biopsies? But hopefully something very interesting happens. And we finally had a game changer in the early detection pathway. And of course, you all know the game changer, which is prostatic MRI. And for the first time, we were finally able to see the cancer inside the prostate. And what's even more interesting, we also had an idea of the aggressiveness of the cancer. And I just want to go back on a few studies, because I think they were so major to the field that we have to take a step back and take a few seconds to look at them again. And one of these studies is the PROMISE study that was led by our colleagues from the UK. And we have to be very thankful for the 576 patients who took part in PROMISE. And I've met some of them during my stay in the UK, and I can tell you that they had a very bad souvenir of what happened to them when they had a biopsy. Basically, these men had an MRI, an MP-MRI. They had truss-guided prostate biopsies, standard 12-course systematic biopsy, transrectal. And they had what was the most ethical solution alternative to a prostatectomy to know what was actually happening inside their prostate. And that was a systematic transperineal template biopsy with the biopsy cores obtained every 5 millimeters in the whole prostate. Just to have an idea, that's a number of biopsies between 50 to 60 for each patient. And it led to a rate of retention of around 10%. And I think it is since then that the risk of urinary retention after transperineal biopsy was raised. And I think we now know that the risk is way lower than that when we do only systematic and targeted biopsies without such a high number of biopsies. Anyway, this study was the first most important study to confirm that the findings of MRI were actually much more accurate than the accuracy of TRUS biopsy in knowing what was happening inside the prostate. So we all know it now, but it was not that obvious at the time. And it is the most thorough scientific confirmation we'll probably ever have of the importance and the quality of MRI in evaluating what's happening inside the prostate. The next study I want to discuss, and you all know it as well, it is the PRECISION study. So just a quick reminder, 500 patients, all biopsy naive. They all had MP MRIs. And as in the previous study, a lot of effort was put into external review and evaluating the quality of MRIs. Actually, for PRECISION, it has been done posteriorly using the Pikewell score, and it was proven that the MRIs were of a good diagnostic quality in over 80% of cases. So patients had an MRI, men had an MRI, and then they were randomized. So if MRI was suspicious, they were randomized between either only around 4 targeted biopsies or a regular non-targeted systematic biopsy with a 12-core protocol. Men without any lesion on MRI did not have a biopsy. That's something interesting to remember. So what was shown in PRECISION? Well, that's very important as well. 2 findings. The first one is that we have level 1 evidence that MRI plus targeted biopsy does better than systematic TRUS biopsy. And that's something very interesting to consider, because we always try to make sure that we always, as urologists, want to confirm the findings of the MRI using TRUS biopsy. Or in some cases, when we have a doubt, we will do TRUS biopsy. But why do we do it when we have level 1 evidence that MRI and targeted biopsy is better than systematic biopsy? That's a very important question that we still have to ask ourselves. Anyway, another very important finding was that actually MRI could also be used as a filter for aggressive disease, because the PIRATE score was associated with the Gleason score of the disease. And with the increasing PIRATE score, we would find an increased probability of finding an aggressive significant tumor. So for the first time, not only were we able to see the tumor inside the prostate and target it, but we were also able to have a filter to know if the patient was at risk of having an aggressive disease, which is exactly what we are trying to do in early detection. So all these data were considered and integrated in the recommendation, but as usual, it actually took some time. And going back to the older versions of our recommendation, I was very surprised to see that it was only since 2018 that MRI was recommended prior to the initial biopsy, following the publication of the studies I've just discussed. But what's very interesting is that we had a few surveys done in France among urologists and radiologists prior to that in 2015 and 2017, and already over half of urologists were using MRI prior to biopsy before it was recommended. So that's something also interesting to consider. So in 2018, the recommendation were still not translated in English, but what was recommended was to perform an MRI, and then we had 2 options. If the MRI showed a suspicious lesion, we would do a biopsy, including systematic and targeted biopsies, and the MRI did not show any suspicious lesion. We had to do a systematic biopsy to confirm the findings of the MRI. Of course, this is evolving because as discussed earlier and based on the results I've just presented, we want to use MRI as a filter, but things are moving slowly because we know that targeting isn't something perfect. We know there's a learning curve. We know that fusion techniques are not available for every urologist. So we are keeping for now systematic biopsies in the template. So what's recommended today is in the presence of a suspicion of prostate cancer. So once we've done all the early detection pathway and we deem the man at higher risk of prostate cancer, so we prescribe a prostate MRI, then if the MRI does not show any suspicious lesion, there is a possibility of not doing a biopsy, especially if PSA density is low. In case of a suspicious lesion, what's recommended is the performance of both a combination of systematic and targeted biopsies. There's no recommendation on the exact number of targeted biopsies needed, but we basically agree on the fact that 2 biopsies is not enough. And mostly 3 or 4, like was done in the precision study, is probably a good option. So what is the ideal pathway and how does MRI fit in this ideal pathway? Well, the ideal pathway is that once we've done the initial evaluation, either the patient is at low risk and we keep repeating the evaluation until his life expectancy is too short. If the patient is at high risk, then we do an MRI. And based on MRI, we decide if we put the patient back in the low risk category without doing a biopsy. And what we would like is for the patient that we biopsy, that they all harbor only significant disease. So we only biopsy if the MRI is suspicious for a high risk of significant disease. And that's a very new concept. And that leads to new problems in practice, such as the need to sometimes repeat MRIs before biopsy, do some sort of surveillance, but before doing the first biopsy. And just to make sure that when we do the biopsy, the man will most certainly have significant disease. So I think this is somewhere where we are going, but again, we will need more data to confirm this. So now that we've discussed where we came from, question is, of course, are we there yet? Are we happy with how the early detection pathway works today? Surely we are contributing with MRI to the reduction of overtreatment by allowing a better selection of men with a higher risk disease. But I think as long as we will be doing systematic biopsy in the presence of negative MRIs, we will still expose the man to some risk of overtreatment. It is something we'll have to study further, but on a population scale, I think there's no other option than to improve the quality of MRI performance and interpretation to make sure that we can actually really trust our MRIs. And once this is achieved, that we can trust the fact that we do not biopsy if the MRI is negative. There are questions remaining. One of them is, how do we select men candidates for MRI? So I've shown you the early detection opportunistic screening option. But maybe now that we have MRI, now that we are able to reduce overtreatment, maybe we should consider screening more largely and doing systematic screening. Another question is the biopsy template we should do. Because, of course, by adding systematic biopsy, we are more confident with the findings of the MRI. We are more confident in not missing significant disease, which we know can happen in up to 10% of cases with targeted biopsies only. But are we not exposing men to a higher risk of overtreatment? That's another question. So to expand on this question of biopsy templates, there so far data are supporting the combination of systematic and targeted biopsy, mostly because it has been shown that this strategy was superior when looking at grading accuracy or site-specific extraprostatic extension prediction. the prediction of lymph node involvement, the risk of positive margins, or the risk of biochemical recurrence. But a new concept is emerging, and it is a concept of adding perilesional sampling around the targeted biopsies. This is based mostly on this publication, looking at men who had biopsies performed using a fusion system with the ability to measure the distance between each biopsy and the center of the MRI lesion. And what they showed is that 90% of positive biopsies were located within a 1 centimeter range sphere around the target. So it is likely that this is where we will gather the most information with our needles. So that is targeted and perilesional sampling. And it has already been shown that this was probably the best solution to define the tumor grades more accurately, and it will probably now be evaluated in other contexts. Looking at the selection of candidates, things are also moving. As you may have heard, the European Union Council has given a green light for the consideration of by each state of the addition of prostate cancer screening to their screening programs, or at least for the evaluation of the possibility of setting up such programs. And we've very recently had some very interesting data from a screening study from the Goëlle 2 trial investigators. So they've invited 17,980 men to have a PSA test with a threshold of 3 nanograms per milliliter. And what they were looking at was whether by using MRI in the strategy and using this filter for aggressive disease, we would reduce the rate of low-risk disease detection. And that's important because less low-risk disease detected means less risk of overtreatment. And they did find that by using MRI as a filter, they could reduce the detection of low-risk disease by around 50%, and only 10 cases were missed by targeted biopsies only. We do not know whether adding systematic biopsies to targeted would have changed something, whether it would have led to more low-risk disease detection, because it was not studied in this paper. And finally, and it's been already discussed, so I'll move fast on it. I think we have to progress also on the prostate biopsy approach. The European Urology Association is now recommending transperineal approach to lower the risk of infection. It is increasing in France, but there is still a long way to go. So we have mentioned it in the recommendation, but so far it's difficult to make it a high-level recommendation, while most urologists in France are not equipped with the technology to perform transperineal biopsy as their standard approach. But it is now recommended every time it is technically possible. And there is one question remaining for this transperineal approach, and that's whether the diagnostic performances are as good as the transrectal route. There are some meta-analyses that give us some ideas, but we are currently awaiting the results of this randomized trial, currently recruiting in France. And the recruitment is planned to end in March. So watch this space, because we should have some data on this topic by the end of the year. So in conclusion, can we say so far so good? We're happy, and now we can rest because we've done the most for our patients in early detection. What we can say from this is clearly we've come a long way from where we started, and we're all very happy that we are not doing systematic trust-guided biopsies, hoping that one of our needles will find the cancer cells. But I'll say, keep watching this space, because I think the best is yet to come. There's a lot to discuss and many changes to be made if we really want to reduce as much as we can overtreatment. That probably will pass through increased uptake of MRI, better patient selection for MRI, and probably stopping doing systematic biopsies altogether, but that's yet to be seen and confirmed. Thank you for your attention.